So this video is on the use of neurodynamics with patients with lateral elbow pain. You bring the patient to the edge of the bed, not too far, otherwise she's going off like she nearly did. We're going to put her in slight side flexion again. So when we are looking at sensitization, we are bringing her back in, which hopefully will unload some of the nerve structures, as opposed to if we go into that might load it back up again and become a bit more painful. So again, in this position, so we're going to have the arm straight like that. You're going to block elevation with your leg, but you're not pushing into elevation, you're just taking up the slack, keeping the elbow extended. So you're going to start off, I do it like that, bring them down. Then we do medial rotation with the elbow extended. We do finger flexion and wrist flexion. And then we abduct. Okay, now you can also do this in standing. I'm not going to because I don't see why I have to. So in this position, okay, we're going to start off with her fingers and wrist in flexion. Now obviously, if that suddenly brings on her lateral elbow pain, do we need to start really going too much further? Well, we need to look at sensitization. So in this position, what we could do, if we've done a little bit of movement in that position, so it's actually affecting up here, just shrug your left shoulder, but keeping your elbow straight. And if that eases the symptoms, we know there's some kind of neural involvement, or if it worsens the symptoms, we know it's some kind of neural involvement, and we can stop there and then just relax. But if we do in this position, so we put them into wrist and finger flexion, elbow straight, doesn't feel anything here. So we then start to turn her around. And again, if that brings on her elbow symptoms, we don't need to keep going. We'll do elevation, keeping the elbow straight and coming back down. But if it doesn't bring it on, we can then start to do it a bit more. So she starts to add abduction. And again, if that does it, we can then start to look at the shoulder elevation. If we're really testing for it, we can then start to add neck movements. So when we are doing this test and we're doing treatment as sliders, flex the wrist at the same time as elevating the shoulder, but the elbow stays straight. So we flex the wrist and the fingers, elevate the shoulder. That is a distal slider. And then we depress and extend. And that is a proximal slider. So we go through that again. So we flex the wrist with the elbow straight. We'll flex the wrist and hand, and at the same time elevate the shoulder. You okay there, Ness? And then for a proximal slider, we do scapular depression and wrist finger extension. So we can also give the patient home exercises to do. Now, the books will show you lots of different things, but it's best if you understand the principle, you can then make up your own. So we know that this position, so elbow flexion, will lengthen the ulnar nerve, because that's obviously posterior, but it won't lengthen the median or the radial nerve. So coming into the wrist, we know that if you extend the wrist, that will start to affect the median nerve and it will start to pull down. If you go the other way, in theory, that will start to move the radial nerve. So what we want to do in this position is we don't want to tension everything. So as you put pressure on one side, you take it off the other, or vice versa. So in here, as they flex the elbow, I'm getting them to flex their wrist and fingers. And then as they come back, they then straighten. So we go finger flexion and elbow flexion, and then finger extension and elbow extension. And then the patient can try that herself. So coming up, perfect, and straightening and bring it, that's it, and back up. And we'll do one more. So as you're flexing the elbow, you're flexing the wrist and fingers. As you extend the elbow, you're also extending the wrist and the fingers. And that is a nice glide for some of the radial movements, which doesn't involve then internally rotating the shoulder if you're in pain, say with the shoulder problem. So if a patient doesn't have shoulder pain, or they're improving with the other techniques and you want to make it a little bit harder, then what you can do is in this position, so we've positioned it so you can see the actual arm moving. What we're going to get you to do is we're going to bring you in slight flexion of the wrist and the fingers. We're going to internally rotate and slightly extend and abduct the hand at the same time as Debbie brings her ear to her shoulder, because that is a glide distally. And then as she comes back and she can open her fingers, that will take it the other way. So for distal in this position, it's wrist and finger flexion. Then we internally rotate, slight abduction, slight extension at the same time as cervical ipsilateral side flexion. Then to come back, she brings her head back the other way at the same time as coming back and extending her fingers. And that is a bit more of a progression if you're really wanting to progress the neurodynamic exercise. In the last video, I demonstrated how to use neurodynamics for the treatment of lateral elbow pain, looking at distal and proximal sliders and tensioners if appropriate.
Hi rehabbers, it's Kevin from the YouTube channel The Rehab Revolution, and this short presentation presents the evidence for the use of radial nerve exercises in patients with lateral elbow pain, and this acts as a companion and provides the references to the video that you hopefully have just watched. That way you know that I am not just giving you my opinion, I am looking at best evidence, or the best evidence that we have, as well as critiquing the evidence, so you will see the quality of it. I will also include the references, so then you can obviously read the studies for yourself and make your own decisions. Now, there is a study by Tedeschi and colleagues in 2024. He did a systematic review on the effects of radial nerve exercises or in the management of patients with lateral elbow pain. Now, the conclusion was that it could be helpful in the management, but I had to go through the evidence and the individual articles to actually get to the methods, the repetitions, the particular exercises, and I will go through them briefly now. So these are the studies that were included. There is one study missing from this list that was in the systematic review, and that is a study that was actually not published. It was a MSc dissertation, so I have not included this. The articles that I am using are based obviously on journal articles and have been through the published process. So you can see on here, we won't have to go through all of these because you can read them at your own leisure. But basically, we're talking about the intervention, so the sliders, sometimes using cervical spine translation, sometimes using radial head mobilization, but they are using the radial nerve test as a form of treatment. Now, the results you can see here. Now, if we look at the top one, so by Vincenzino, the improvement was 1.9 in the VAS score, so the visual analog scale. So is that useful or not? The effect size that the paper reported, so this is basically how applicable the results are to the patients, and that was 0.7. So the higher it is, the better it is, up to 1. I also put in here the MCID, or the minimal clinically important difference, as well as the risk of bias. So a lot of the studies talk about statistically significant and give you p-values, and that is good, but we also need to know if this is actually clinically significant. So that is why we use the MCIDs where they do exist. Now, if you start at the top, so the MCID, it was achieved because some of the evidence is suggesting that the MCID for the VAS is 1, although an improvement of 1 on a visual analog scale for pain can make your own decisions on whether you think that would be useful. Now, this study had 1.9, so nearly double the MCID. Again, if a patient has 9 out of 10 pain and it goes down to 7 out of 10 pain, is that significant for the patient? Well, I'll leave that to you. But there are some concerns with the methodology, as I put on there. The second study by Dressler, again, this time they used a grip strength as an outcome measure, and they did show that the use of radial nerve exercises improved the grip strength of patients. We couldn't go through the MCID on this because there was no information. The problem with this study though is, and the next one after that, is there is a high risk of bias. The third study by Dabal did show improvements. So for example, the VAS went from the VAS scores between them. If you do or compare radial nerve exercises versus eccentric strengthening, then the VAS difference in favour of the radial nerve group was 2.3, which did meet the MCID. The control group had a difference of 1.9. So again, you can see in this group, both groups actually met the MCID for the VAS, which is greater than 1. So the radial nerve sliders, radial head mobs, but also the eccentric strengthening exercises for the wrist extensors. There is also significant improvements for both on the patient-reported tennis elbow evaluation, the PRTEE outcome measure. Now, the minimum clinical important difference for this outcome measure is 14.8. And you can see here that the radial nerve group demonstrated a 19.85 improvement, and the control group actually demonstrated a higher improvement, 23.8. So again, both groups did help patients with their pain. But again, there was a high risk of bias. The Arumugam study in 2014 used radial nerve mobilizing techniques using the actual nerve test position, and they did show that the numeric rating score decreased from 5.7 before they did the exercises to 3.8 after they'd done them. So an improvement following the program of 1.9. The problem is this did not meet the MCID for the NRS rating for pain. In this case, the MCID for the numerical rating scale is 2.3. So although they did improve, it was not classed as clinically significant. And again, there was a high risk of bias. Now, the final study we can see by Yilmaz in 2022, they compared the neuromobilization exercises with eccentric strengthening, and they found that there was significant improvement in the VAS score at rest following the use of neurodynamics. So at the beginning, their pain score was 4.5 on the VAS. This decreased to 0, so pain-free, at 6 weeks. Now, the control group for VAS, as we've mentioned, is the VAS MCID is 1, so the control group did improve as well, but you can see there was a greater improvement in the radial nerve group for pain at rest. Pain at night also showed improvement. So for the radial nerve group, it improved from 4.7 to 0. So again, pain-free at night after 12 weeks. It did improve as well in the control group, but not as significant as the radial nerve group. And then finally, the VAS, or the VAS with activity. This improved, again, significantly in both, meeting the MCID, but the radial nerve group went from 7.23 on the VAS to 0.5 at 6 weeks of doing neurodynamic exercises. The control group did improve, and they went from 6.03 to 2.56 at the end of the study. So in conclusion, we can see that there is evidence for the use of neurodynamics in the management of patients with lateral elbow pain, although the study quality is questionable throughout. I hope this was useful, and I hope you enjoyed the video.